important topic we are having with Dr. Naveen Pavaskar. Homeopathy in COVID-19 infection. Friends, today is very important day for all of us because we are having such a learned personality, such an experienced personality, Dr. Naveen Pavaskar, who has wide experience in his clinical research. If I start sharing his resume with all of you, maybe it would take half of the time of the session. It is so long, 10 pages. I cannot read all these things. He is very learned personality, so I would share some of the important things regarding Dr. Naveen Pavaskar. Dr. Naveen Pavaskar's education is from various universities, from various institutes. Gupta sir, good evening, M.K. Gupta sir. Can you hear me, Dr. M.K. Gupta sir? Sir, can you hear me, sir? Okay, okay, sir.
Hello.
Hello, Gupta sir, yes, please.
Very good evening, Dr. Tanveer.
Sir, your voice is audible, but it is feeble. It's not that audible, but we can hear you, sir. Okay.
Audible?
Gupta sir, not clearly, sir. Not clearly, sir. Gupta sir, you are not that audible.
Hello.
Hello, I can hear you, but it's not clarity is not there, sir.
But your voice is audible. Your voice is clear.
So you can remove the headphones. You can start talking directly from your phone or from your laptop also, maybe. Okay.
Hello.
So, friends, Dr. Naveen Pavaskar's education is as I am reading now. He has done his MBA from University of North Carolina at Chapel Hill from USA. He has done his MS, that is from University of North Carolina at Chapel Hill, USA only. From Mumbai University, he has done his MD in practice of medicine. Doctorate of Medicine in Homeopathy he has done from Mumbai University. And he has done his Member Institute of Clinical Research from Institute of Clinical Research, India. And regarding his projects, he has been director of various projects like Primal Project Director, Hospital Planning and Operations in 2014, Validas Healthcare Director, IT Application and Design 2015, Jim's Healthcare Institution Building Design Planning and Execution in 2013, Arab Integrative Healthcare Founder and Director he has been in 2020. He has been independent healthcare consultant and various, there is a long list of his clients. I can read a few of them. One is GR Integrative Medical Services, Hyderabad, Chief Consultant Plan, Build and Operate in 2013. If I start reading, I think these are more than 20 years been involved in all that projects. And as far as overview of healthcare experience is concerned, there is emergency management experience. He is having very vast experience for that. And crisis and disaster management experience, he is also having very vast. Even he was involved in in industrial ammonia leak. Gujarat earthquake, he was also involved in his research. Administrative experience is there. GR Integrative Medical Services in Hyderabad, he has given services from 2010 to 2019. And from Dr. M.L. Dhavle Memorial Organization, he is basically attached with it since a long time, from 2008 to 2011. And he has been director in the health hospital services there in various programs. Coordinator IPD council also he has been there. Rural Homeopathic Hospital he has been involved in there in Palghar in India from 2002 to 20. It's a very long list. I have read few of them. So friends, today we are lucky enough to have Dr. Naveen Pavaskar again with us because it is his second webinar with IIHP. First he was there with us in the past also. So taking not much of your time, Dr. Naveen sir, I would request you to start sharing your screen so that we can start our session because you are having so much information today to share with the profession. So I request you, please start sharing your screen so that we can start it formally.
Yes, sir. Is my screen seen?
Yeah, it is. Yeah, it's visible, sir. Your video and audio and everything is clear, sir. Yeah.
Right. Is it? Tanvir sir, can you hear me now?
Yes, sir. Very, very clear, sir. Your voice is very clear.
Okay. My screen is visible, right?
Right, sir.
And it's moving. Can you
It's
see
not
the slide?
moving. Yeah, yeah.
No,
Now it's
you see the
moving, sir.
second slide now coming up, right?
Yes, sir. Yes, sir. Yes, sir.
Okay.
Yes, sir.
So now we are good to go. Thank you. Thank you, Tanvir sir, for all
Thank you,
the
sir.
kind words. Let me be, all that is what has been said by Tanvir sir is appreciated, and thanks for all the good words, sir. But what is more important is what we are going to talk today, because this
Right.
is something that came as a surprise to all of us in 2009, 2020. And well, let me be very, very frank. Uh, okay. I was practicing until 2011, 2010, and then I moved into another profession for my own sake. For after having worked in homeopathy for almost from 1994 until 2010, I moved into another profession, just to have being happy about what I did with homeopathy and wanted to do something more in another profession. But COVID brought me back to the practice after 10 years. So practically from 2010 to 2020 uh, has been a 10 years long gap. And after that, I uh, joined back into practice just to serve from a COVID perspective. I have no intentions of start keeping this on further. And once COVID winds up, I will move back to my profession again. But nevertheless, whatever I have gathered, it's worth sharing with all of you. And thank you for the opportunity, IIHP, Dr. VK Gupta, Dr. Amy Rao, Tanvir Hussain sir, and all the members of IIHP. I thank you all for this particular opportunity. So our today's agenda, I have labeled our topic. Titled our topic as homeopathy in COVID-19 infection. But the more important thing is the spectrum of kaleidoscopic patterns, because that's really what was observed in this last 6 months. We could see patterns of infection and patterns of human reaction to those infections, and that really helped us understand COVID-19 from a homeopathic perspective. So we have a long list of things to do today. This is going to be a 30,000 feet overview. I'm bringing in cases here just to demonstrate the scope at which homeopathy could be applied. And at the end of the day, if I can convince all of us that applying homeopathy in COVID is not a rocket science, it is as simple as what we do in our daily practice, I think my day would be done. So if anybody's come here to see something spectacular, you're going to get disappointed. If anybody has come here to see something very complex, again, you will be disappointed, because what we found at the end of 6 months of struggling with COVID is that it's not very difficult to treat. So sometimes the answers are simple, and it's just that we have to find out where they are and seek them, and that's where it is. So we will be talking on completely practical aspects of treating COVID-19. I don't have a single theoretical slide to show you. And it's all applied homeopathy from primary and secondary contacts of COVID patients to asymptomatic COVID patients, symptomatic COVIDs with comorbidity, pediatrics in COVID, pneumonias, and even the workplace outbreaks. So we will go one by one. And I can assure you, whatever I am saying here is already there in the textbooks. So nothing spectacular, new, or complex that is going to come. It's only to make sure that we all know that homeopathy has its complete application in COVID-19, and that's the only objective. And that it is not a rocket science at all to apply homeopathy in COVID-19. If at the end of this day, if all of us go home saying with this message, I think we've done our job. So let me, Tanvir sir, I am able to see your screen. Can I, which probably is blocking the view.
I think it's which one?
There is one screen which I see on my thing. Is it blocking your view or is it just in my view that it is seen?
No, it's not blocking, I suppose.
You are able to see the full screen, right, sir?
Yes, you can make it little minimized because there is a small icon on your left
Ah.
side. So little make it
No,
minus
this is
one.
okay. I am able to see, sir, so no problem with that. But if it's not blocking anybody's view, we'll proceed
No, no,
at
it's
this
not
point.
blocking, sir. It's okay. It's okay, sir.
Yeah, yeah.
It's
Thank
fine.
you.
It's
Thank you
fine,
very much.
Naveen.
Yes, thank you. Thank you very much. So, this is the survey that we conducted at REV. I'm speaking on behalf of REV. REV is a team of homeopathic doctors practicing there, and I am a part of that particular team. So we conducted a survey for people who were affected by COVID and people who were exposed to COVID as consumers, and we realized we got around 884 responses. Still, the survey is on, but the responders included all kinds of people in the field: healthcare professionals, police department, fire department, everybody who was supposedly high risk individuals. And what we were able to has it moved? The slide has not moved.
No, 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 sir. No, no.
Okay. Yes. Now I think you see the next
Yes.
slide. Okay, thank you.
Age distribution.
Yeah.
Yes, age
Yeah.
distribution. Yeah.
Okay. Yeah. So this was the age distribution that we found, which completely, this is a random survey, but you see the age distribution matched absolutely with the way high risk population was distributed in COVID-19. Obviously, male were more responding than the females. Now, when we asked them a question that how many of them actually used homeopathy before COVID-19 for any of a chronic illness, and as this exactly matches the national survey, because they said around 4% of people in that group had used homeopathy previously before getting exposed to COVID-19, and in other than COVID-19. And when we ask them how many of you used Ayush immunity boosters in COVID-19 or any kind of Ayush medicine, so you see from 4% it jumped to 45%. Now, this is precisely what I wanted to tell you, that 45% of people new, so almost around 40% of people who were never exposed to homeopathy or Ayush started using Ayush systems of medicine. So this is one real good thing from a market perspective. And then we asked them what kind of which system they which kind of medicines they used during COVID-19. And as you can see, almost 24% of people used additional, I mean, people who were not using homeopathy, additionally 24% people started using homeopathy more during the COVID-19 period. So this is a first-hand experience that we are coming from a consumer perspective, and you can see that we try to seek their opinions on all kinds of Ayush systems of medicine, and this is what we found out. There's much more in that survey, but I don't think that's relevant right now. What I'm trying to drive home here is that a lot many people have started using Ayush systems of medicine during COVID-19, and I think homeopathy is one of the leaders that has turned out to be there in the Ayush systems of medicine um, that was distributed and utilized and consumed very well. There are enough commercial reports which say that the consumer sales for Ayurveda and homeopathic medicines have gone up, and so is the macroeconomics talking about it. But this is first-hand experience that I can say that had happened. So COVID, we essentially divided COVID into three: COVID patients, primary contacts of COVID, and general prophylaxis. So when I'm going to talk about this as the lecture unfolds or as the webinar unfolds, so first we will talk about the general prophylaxis. So we started interacting with COVID way back in way back in March, and we distributed arsenic alb 30 as per CCRH guidelines, almost to 54,000 families. Each family consisted of we distributed medicine to each family consisted of around 4 to 6 people. So you can understand that the distribution went almost up to 3 lakh, 2.5 lakh people. Now, this distribution was done free of cost to all other people as well. I think a lot of us did that. But what was, and these are some of the testimonials that we received. Uh, Again, why is it? Yeah. But I am more interested in sharing this with you. The testimonials are important, but what is important now today is this, that we took a sample size of 10% of people that we distributed medicines and asked them what happened. And if you could see that, even though we distributed arsenic album to everybody, not everybody consumed, and they were frank enough. So we pragmatically got two groups: one, those who consumed arsenic album, and those who received arsenic album but did not consume it. Okay, for whatever reasons, they may not have trusted us, they may not have trusted homeopathy, they may not have trusted Ayush systems of medicine, whatever it is, but they did not consume it. They did receive but did not consume it. And as you can see now, what happened to them during the last 4 months. Total subjects that so we took a 10% sample size, and this is what we could see, that there was not much of a difference between the incidence rate. But what happened is that the morbidity factor of the illness, you see, is almost half in people who have taken homeopathy. The number of admissions that occurred is almost one third that in people who have taken homeopathy, and also the death rate is impacted. So I could clearly understand that the morbidity of the illness for people who consumed homeopathy during this period was definitely impacted, not so much the incidence. Now, this is if you look at the whole India data, this might just be a very small sample, but nevertheless, it is very indicative. And we should, bigger studies and larger studies would also help us understand this better. We are, trying to compile more and more data from, but as of now, this is how the picture looks. So definitely, the morbidity was much less. You could see that the home isolation people were much bigger, the admitted numbers were less, and the death rate was obviously much, much less than what was there in the other people, for those who did not take homeopathy. So now we would go into, so this is as far as the general prophylaxis is concerned. And then the next thing that comes up is prescribing for primary and secondary contacts of COVID-19 patients. So what we realized when we realized that the incidence rate with this particular strategy that we used was not, 1 minute. So somehow the slides are not moving very smoothly. So bear with me on this. Right. So providing support to the primary and the secondary contacts of COVID-19 patients. That was the second aspect. If you see, I showed you three goals, three circles around. First was, general prophylaxis to the community, and where we distributed arsenic alb as suggested by CCRH as per their schedule. And we gathered our own data from, 10% of what we distributed, we could gather data, and the data is there in front of you to see. What we did at the second level of defense or the strategy was I was involved with Dr. Dikshit in this particular venture of his, where we mounted Zinc Met 6C and China R6C on Calcarea Phos 6X and created a formulation. And it was distributed only to primary contacts of people who were exposed, who had COVID-19 in the family. and we had number of doctors. A lot of our good doctors with Dr. Dikshit's team were also monitoring these primary contacts on day-to-day basis. So it was not as if we distributed it and forgot about it. The data of each patient to whom it was given was monitored for his health for a period of 4 months. And what we realized is out of 1,200 people that were there, only 79 were detected positive. That's around 0.6% of the illness, which is much less than the normal incidence rate in the community. And of all the people who turned positive, there was zero mortality. So this is one impact that we could very, very clearly see. One is that this was less incidence, even when the patient was directly exposed to a COVID-19 patient. And second, the incidence was much less in the community, in the patients who were exposed to the COVID-19. And those who were exposed and got positive suffered very less with very moderate, mild to moderate illness with zero mortality. So this encouraged us to put this strategy as the second level of defense. So if you miss through the arsenic, this is what we put across our team, our people who were there. So at RE, when based on this experience, we had 35 primary contacts of COVID patients who were prescribed calcarephos, zincomet C plus China R62 tablets twice a day for 14 days. And 34 out of 35 did not develop any symptoms. All of these 35 patients were tested for RT-PCR, and none of them turned out to be positive. Even they were exposed and living with the patients of COVID-19. So none of them turned out to be positive. And the one person who turned out to be positive was detected positive. On further detailed inquiry, he revealed that he did not take the prescribed calcarephos, zincum, and the formulation that we had prescribed. So I would say that this was an important revelation for us to understand how do we manage the primary contacts who are just exposed definitely to COVID-19, and they are living in close proximity with COVID-19 patients, but have not yet developed symptoms or who have not yet tested positive. So now you look at this, that the first level of defense was arsenica. The second level of defense is what we learned out of Dr. Dikshit's experience by working with him. And mind you, we have set up a registered clinical trial for this, and which is just now completed its clinical phase. And we are in the phase of data collection and the data compilation. So maybe a month or two, and we'll be out with the trial results as well for this particular study. So it's a randomized trial that we have conducted, and I'm hoping that we will be able to come out with these results and present it to you at some point of time. So then comes the next level of thing, managing, prescribing the asymptomatic COVID-19 patients. So asymptomatic, that means they have tested positive, but none of them have symptoms at this point of time. So how do we actually manage them? What is it that we look forward to them? Now, why do we manage an asymptomatic patient in the first place? We manage a primary contact because we don't want him to get positive. We don't want him to he's exposed to COVID, but we don't want him to get infected with COVID. Now, in asymptomatic positive patients, they are already infected with COVID. So what we are trying to see is reducing their morbidity, making sure they don't fall, don't get critical and don't need admission and oxygenation. That should be our objective. And the last thing is to make them free virus as early as possible. So I think somebody has his microphone on, which is probably disturbing. Can you please shut and put the microphone off if you can? Thank you very much. So prescribing in asymptomatic patients was a very interesting challenge that we got. Now, this is a story in a workplace. There was a workplace where out of 123 workers, 92 tested positive in 4 days. And you could see the date-wise RT-PCR positives. On fourth, we had 3 positives. On fifth, suddenly there was a jump of 26, 28 patients. On sixth, it was 17 again. So in a span of between 4 and 8, we had 92 workers positive in a single workplace. and they were all there was a panic in that organization because the organization had to that workplace had to shut down at that point of time. So yeah, uh, may I request, there's some microphone on in the backdrop. Can you just switch off the microphone if you can?
Dr. Hardik Shetty, please keep your microphone on off. Unmute yourself, please. Mute yourself, please. Hardik Shetty, sir.
Thank you, sir. So these 123 workers out of 92 tested positive. So there was a situation on hand about what is to be done. So what we did is we actually, there were only 8 symptomatic patients in those in that 92 patients. So what we did is we studied the symptoms of all the 8 workers who were positive, and all that we could find that they had common symptoms of they had a commonality in their symptomatology. All of them had fever with headache, all of them had fever with body ache, and all these 8 patients said that their thirst had increased. So based on the totality of these 8 patients, not only were these 8 patients given bryonia, but rest of the 90 to 84 patients who were completely asymptomatic were also prescribed bryonia. Now, this is classically what our organon talks about, that you study the symptoms of patients who are symptomatic and then use the same remedy for people who are in the close proximity and who are yet not suffering but positive. And this is what they were observed in under home quarantine for 10 to 12 days, and the 8 symptomatic patients were sent to the COVID centers. And all the tests were repeated after 10 days, and all 84 asymptomatic as well as the 8 symptomatic patients turned negative between 1 and 10 days. So you could understand that nothing else was required. It is just that you had to know the symptomatology of 8 patients to be able to predict what is happening in that entire workplace where everybody was working together and had a very close proximity with each other. All of them required the same bryonia based on the symptomatology studied for the 8 positive patients and all of them were tested on day 10, between day 10 and day 12, and all of them tested negative. So this is, how a workplace outbreak could be managed, or, this is how one can look at when you see a pattern which is similar in all the patients flowing in. This is where all other asymptomatic positives could be managed when we had symptoms of the 8 patients who could give a very, very clear pattern of bryonia that was emerging at that point of time. I don't think we have to explain bryonia here. It's very simple to understand why bryonia was prescribed. But what is important to understand is how do we treat a workplace outbreak when we have a large chunk of asymptomatic patients with a very few symptomatic patients working together, and what could be the remedy that might help all of them at this point of time. And this is precisely what is mentioned in the organon. Now, what happens in prescribing symptomatic patients? This is where, individual who gets infected with COVID-19 exhibits a different kind of symptomatology. Each person has a different set of symptoms, and that symptomatology now needs to be identified to be able to prescribe that particular remedy required for that individual. So here it's not one size all phenomena. Whereas in this case, where we had these asymptomatic patients who were already positive, working in the same place at the same time, turning out to be positive was very important. They were all at the same time between 4 days. They all 92 of them had turned out to be positive. So that means something was happening in that particular workplace, and the phenomena was very, very similar. It was like a small outbreak in this entire epidemic. It was like a small outbreak in that entire epidemic, which bore exact similar picture for all the 8 patients, based on which we prescribed for rest of the 92 patients and observed them as per the guidelines. And all of them luckily responded and turned out to be negative at the end of 10 days. Nobody had to be hospitalized. Nobody had to be given oxygen. Nobody even developed symptoms. And only those 8 patients also reverted back home from the COVID centers. but this is not the case. So do we give Briannia to everybody whom we find? The situation is that is not the right thing to do. We don't give Briannia to everybody. So there are patients who exhibit different set of symptoms, and those set of symptoms have to be studied before a remedy is prescribed. So we don't compromise with individualization when individualistic totality is definitely available in the patient. So these are all very, very initial cases. And what I realized with these cases is they were very mild kind of infection, but they were nevertheless, they taught us how to, initially interact with COVID. So this 45-year-old lady, got exposed while travel, had to travel on the flight, and then got exposed in the rain, had to visit the hospital. So she got exposed to all possible COVID exposure that would be needed for somebody to come positive. And so developed mild cough and coryza. That's it. But the more important thing was it started. Now, mind my word, how did your COVID? This is the key question that we were asking everybody. How did it start? What was your first symptom? What was your second symptom? And what was your third symptom? And you see how it started here in this case. It was backache, leg pains, and fever. And this to us was a very important information. It started with backache, leg pains, and fever. Okay. So how the evolution was very, very, very important for us when we were prescribing. And then we could see that there were other symptoms as well, restless leg pains, better by constant changing of position and all that. I don't think that we need to, keep a guessing competition here as to what remedy would have been prescribed. Rustox was prescribed, no rocket science here. And the fever, tapered down in 24 hours. In 48 hours, the patient was asymptomatic, and so developed antibodies against COVID. So this is a very mild case, initial, responses, which help us understand how do we go on managing this, COVID scenarios that are going to unfold to us. A similar case, very mild type, 25 years old male working for an IT company. Here again, look at it. Look at the this thing, low backache and abdominal pain. Okay, look at the starting point, low backache and abdominal pain. This is what was the presentation. The rest are all practically common symptoms. Soreness of throat, sneezing, cough. They're all practically common symptoms. But what was peculiar to us was how did it start? What were the first 3 or 4 symptoms that happened? Okay, both the parents had fever and they were tested positive. He was taking paracetamol and medicine for, and yet the fever was not persistent. Patient was detected positive on 22nd of this month. The chest CT scan was NAD, and but the patient was febrile in spite of taking all this thing. Further inquiry, we found that the thirst was reduced. There was headache, and there was constipation with unsatisfactory stool. Again, uh, no, no prizes for guessing the remedy. It was Naxwamika, and but to us, what we were learning here was we were trying to track what were the first 3 or 4 symptoms that you developed before you developed the full blown picture. What were the first 3 or 4 symptoms that you developed? This is what we were constantly tracking, and as we go ahead, I will tell you why I'm emphasizing so much on this particular point. Once again, here, he eventually turned out to be positive, but settled with Naxwamika completely, did not have to be admitted, no antivirals required, no antibiotic required, and uh, they the patient had to be moved out from the house because he was positive and there were other patients in the house, and he remained very stable until discharge with no symptoms after this. So, after having learned this milder experiences, we encountered pediatric patients. Now, there was once, kids come positive. I think it's a panic everywhere. Mothers are on, they get into panicky mode. The family is worried when the kids are positive. They are not able to give symptoms. Now, this is about a 2-year-old baby who lost his mother day or a couple of days or a week before, and uh, had to be, was exposed during the ceremonies and the other times, and started developing fever. During the fever, child was extremely restless, did not like to be covered during the fever. The thirst increased than usual, and when the child earlier was known to be a hot child, by hot I mean thermally hot, very restless, wouldn't want to be covered even during the winters in Delhi. So, considering all, that he was a hot child, extremely restless during fever, thirst increased, and exhaustion developing, we prescribed, at that time when we prescribed, the temperature was 103, pulse was around 120, liver and spleen were already, liver was 2 fingers palpable, and the child was looking weak and toxic, and all the three family members who were who were living with him had similar fever and had turned out to be positive. So there was a panic around over there. We gave arsenic iode 200 4 times a day, and just monitored the child at home. And later, the child settled in 12 hours, started looking up with this, the generals improved, and the child was up and looking around. The fever was still persistent around at 101, though it had come down by 2 degrees. Appetite was increasing, was accepting food, and in 24 hours, the fever settled down. Child was afebrile and moving around and playing around. So this was, something very heartening, that even, I mean, it looks like a usual fever when we look at it from this perspective. Now, this is about a 13-year-old male who's a known bronchial asthma, who's constantly on inhaler. Now, this is a risk factor in kids. Asthmatic children, when they get positive, it is certainly a risk factor in the kid, in children. And so the observation was he is the weakest child, and if any sickness comes in, it takes very long time to respond in this particular thing. How he turned out to be positive is because he had been to a some ceremony. 1 minute again. Okay. Attended a wedding on 10th, and on 12th was informed by somebody that one of the attendees turned out to be COVID positive. And so patient's RAT was done, rapid antigen test was done on 12th, uh, which turned out to be positive. And hence the PCR was repeated, and on 13th it was confirmed that the child was positive. So, an asthmatic child who had wheeze and turning out to be positive was again, a situation where everybody is concerned and everybody gets worried about what is going to happen there. Um, so, again, what was more important is we were trying to understand what are the first 3 or 4 symptoms that he developed. Again, why, if we could find out that though he had a full blown picture, there was a gradual rise of fever, there was headache during fever, and headache caused giddiness. This is what were the symptoms that were the first 3 or 4 symptoms that he developed. So slow onset, headache with fever, and vertigo with headache. These were the 3 symptoms that were there predominantly in the initial part of the period and of the fever, and that's why we prescribed him Bryonia 200. The fever peaked the same day. Patient developed mild cough and coryza, but never required inhaler thereafter. The fevers on the a couple of days from then settled down to 99, and thereafter the child was completely afebrile and completely active, not requiring any inhalers or treatment for additional treatment for asthma as well. So Bryonia could take care of both the aspects, the COVID part as well as the asthma part. No antivirals required, no antibiotics prescribed to any of these kids. 9-year-old, female. Again, the same thing. What we were looking out is what are the initial symptoms? The knee pain, the shin pain, the stiffness developed very early in this particular child, and headache came up. So I think um, no price for guessing again that when stiffness develops, when headache develops, and when you have body ache, you know that this is stiff and body pains with headache is nothing else than bryonia. So this child also was responded to bryonia. Again, in this family, all other 5 family members got fever and tested positive for COVID-19. So then coming to the next level of patients, that is COVID pneumonia patients. Um, okay, so we are 45 minutes from the start. COVID pneumonia patients were um, uh, uh, again not very different from treating, except that we had to be more careful. But the treatment pattern did not change much. Let me be very, very, very frank about this. That the treatment pattern didn't change much, except that we had to be clinically more alert and and most of them, because they were admitted in the hospital setups, many of them went through the course of antibiotics. Later on, as we got more and more confident, many of the patients just avoided antibiotics, and few of them even avoided antivirals as well. So this was possible later as we gain more and more confidence in treating these things. But these are some of the initial experiences what we are talking. A patient had fever and body ache and mild coryza and cough, and RT-PCR was negative on 15th. Nevertheless, antibiotic and other allopathic treatments were taken, but had no relief. Was not sure what's actually happening over there. So we advised him to do a CT scan, and the CT did show multifocal infiltrates involving 10 to 15% of the lung, with CT severity score around 13 out of 40. That's around CORAD 5 correlations. Now, this is one thing that we found out, that RT-PCR negative with people coming with symptoms is saying that it's not COVID is not a right thing to do. You need to screen them through chest CT. I think by now everybody knows this. We need to screen them through chest CT and make sure that though the RT-PCR might be negative, the chest CT turns out to be indicative of what is happening inside. So this patient turned out to be positive on a chest CT, and hence we repeated the RT-PCR, and that turned out to be positive. Uh, he was under treatment in the hospital, was advised antiviral, steroids, and antibiotics. Took all of them, but yet remained positive, and hence on 24th contacted for in spite of being positive for with antiviral, steroids, and antibiotics, he contacted us for homeopathic medicines. And so these are the CT scan and the PCR reports for you. Again, it's a case which has come to you after 6, 7, or 8 days, and so what do we need to look at? I'll keep stressing this again and again to you. Find out first 3 symptoms that happened to this particular individual, and he came up very, very clearly. I had fever, followed by body ache, and it was very, very gradual, and I had eye pain and a headache. That's it. So we went by the original picture that was existing before antibiotics, antivirals, and anti-inflammatories were prescribed. And we prescribed Bryonia 200 4 times a day. He came to us on 24th. By 26th, patient was already better. 27th, he was completely asymptomatic, maintaining his SpO2 and temperatures to be normal. By then, he already omitted his own because he realized that nothing else was working. All of the medicines could be stopped. and by 31st week, he was completely asymptomatic. So, and these are his investigation. He turned out to be negative. As you can see, not only that he responded symptomatically, but his RT-PCR also turned to be negative. And this was a patient who came to us essentially because he was not responding to antivirals and antibiotics. And good thing that we always did in our setup was to make sure RT-PCR was negative, but also they developed COVID antibodies, because that would be something that was very relevant. That if we are prescribing homeopathy, then COVID antibodies, profound COVID antibodies had to be developed, because there are a lot of patients whose RT-PCRs are negative, but they also don't develop antibodies. Now, that's not a good condition to be in at this point of time. So this is a case of a 48 years old female again, a pneumonia once again. Why did they come to us? They traveled for a housewarming ceremony for 150 kilometers. Father turned out to be positive, was hospitalized and was on ventilator. And the lady came out to be positive with, again, for her, with fever, what happened is her thirst suddenly started increasing, and she was unable to drink. She wanted to drink, but she was not able to drink. And then there were body ache and headaches. Again, no big deal. We simply prescribed Bryonia based on the first three symptoms: thirst, body ache, headache. That's it. So by now, I think you must have realized that we were looking for combination of patterns for first three symptoms, right? So was it abdominal pain with low backache and constipation, or was it headache, body ache, and thirst increased, or was it slow onset with dry cough? We were only looking for these first three or four symptoms that would evolve in this particular patient, because the rest was all going to be muddled up, because people were taking all sorts of medications at that point of time. So we would not get the original modified picture. So all that we asked patients was, tell me the first three or four symptoms that developed in you and talk more about them. So our case taking was, hardly 10 minutes. We would hardly require 10 minutes to come to a conclusion on what remedy to be given. Second point was it reduced the exposure of our physicians getting exposed to them, because the amount of time required to prescribe a medicine became very, very less, and it prevented many of our people coming positive. So, already was feeling, so this is when we prescribed on 2nd, and by 4th the patient was already better, but feeling better. RT-PCR was advised, blood CT was advised, chest CT showed CORAD grade 4. Admitted at that time, people were getting admitted because they were COVID pneumonias, but did not require anything. No need for oxygen. Oxygen saturation was maintained at 95 and 97. Without oxygenation, remained in the hospital, did not require any other medications. And only thing that they were insistent at that point of time. Now, what I realized is that though homeopathic prescriptions remained constant, the modern medicine protocols were changing from time to time. So during the June-July thing, using antivirals was a very important thing. And that's why they were insistent on using antivirals, though the patient was completely asymptomatic before even starting antivirals. So now, this is, are all pneumonias Bryonias? Well, this is something that tells us. Now, this is head of a media organization who walks in with very wet, mild cough with yellowish discharge. That's it. This was the only symptom he had. His thirst had gone down, and he had lost a little bit of appetite. And history of recurrent cold whenever exposed to cold weather. Had history of contact with COVID-19 positive patient. Had tested himself but was negative after 5 days of exposure. And he had a comorbidity of 5-year hypertension since past 5 to 10 years. So, simply first three symptoms: thirstless, nose block, yellowish expectoration, and slow pace of illness. We prescribed Pulsatilla 200, multiple dosages. And we insisted that he is COVID positive. On 22nd, he turned out to be positive. He was very reluctant because his first test was negative. But we were very sure that this is going to be COVID. So we requested him to do it again, and it turned out to be positive. But never maintained, the fever always remained 99 and 100, and very low symptomatic, not much of a thing. There was no need to suspect a pneumonia, but we knew this would turn out to be pneumonia. And as you can see on the right hand side of your screen, the chest CT clearly showed that there were pneumoniatic patches, and his RT-PCR was detected. So pulsatilla is all that we continued on him, and again, then we admitted. I checked all his 4 family members; all of them turned out to be positive. Completely asymptomatic even before, just one day after the test had come positive, and remained asymptomatic with no impact of comorbidity, that is hypertension, on his COVID outcome. Here again, just a 59-year-old gentleman had visited a function and had only one symptom, mild and dry cough. That's it. No fever also. We insisted that you get a chest CT done, and the chest CT turned out to be, HRCT turned out to be positive. That's 4, and that's it. But when we further found out, he had 3 more symptoms: just dry cough and constipation, and a very slow presentation. He said very clearly that I am constipated since last 3 days. Since the cough has come, I am constipated. That's how much he said. And it is very gradual. I don't feel much, but that's it. And when the pneumonia, when this is HRCT came out, he himself was amazed as to, am I having a pneumonia with only these 2 symptoms? That was the situation that we had, and we had given him bryonia. Afebrile, no cough, comfortable. RT-PCR turned out to be negative with no complaints. Right. So this is how. Yeah, those are the reports for you. RT-PCR negative, HRCT reports. No, sorry. Yeah. So this is the next case. So this gentleman, was working on oxygen pipelines for hospitals, setting up hospitals in government hospitals, especially setting up COVID centers themselves, and was complaining of body ache and acidity since fever. Temperature used to be 101 all the time. So we got his test done, both positive. The HRCT was showing pneumonia, as well as the COVID was positive. He's a hypertensive, diabetic, and also has other comorbidities. He's obese as well. So again, with very simple thing, we prescribe bryonia. Afebrile since the next day itself. SpO2 maintained, did not have to get admitted in the hospital. No antibiotics prescribed, no antivirals prescribed. IL-6 was high, CRP was high, ferritin was high, LDH was high. We just managed with bryonia. All the parameters came out to be negative, and his RT-PCR turned negative on 26th of this particular month. Here again, patients have to have belief in you. If we said that I don't think you need to take any of these antivirals or antibiotics, as on today, they happily consented, and stayed with us, luckily, and that's what it is. This is your RT-PCR report turning out to be negative. So we can understand that there were patients who presented with florid symptoms, were patients who had flu-like illness, and there were patients who presented with very few symptoms. They were the ones who actually had developed pneumonias. By now you would understand this. The first 2 cases of Rustox and Nux vomica had florid symptoms. They are 5, 6, nice, good influenza-like symptoms. Whereas people who are presenting with meager symptoms were the ones who are presenting with COVID pneumonias. This is where it is. And bryonias and pulsatillas have come up very very profoundly. I'll show you the statistics as we move ahead into how we arrived at these shortcuts, or what we call as focusing on just the first 3 symptoms of the presentation and looking at original unmodified picture and not waiting for people to come up with complex pictures with antivirals and antibiotics. So what is prolonged and COVID-19 pneumonia? Now this gentleman complained of fever since 6/7/2020. All the thing had a poor saturation of 85, vomited once or twice. Again, the chest showed CT positive. He had pneumonias. So we prescribed him Naxwamika at that point of time. Yeah. So we prescribed her Naxwamika, headache, body ache, backache, and thirstless. These were the symptoms that she had at that point of time. Was advised admission, refused it, started oxygen because her O2 was dropping at around up to 85 or below that. Fever reduced in 3 days. Dyspnea was better. Saturation improved with Naxwamika, but the cough was persistent still. So even after if you can see, her illness started way on 6th. The acute phase settled, including the saturation coming back to normal, but the cough was persistent, and she had that CT. Her chest CT was positive. Then she suddenly developed gluteal pains, which were extending until and more so in the night. It was almost neuralgic pains that she developed, and the sleep got disturbed due to pains. And then later she started developing loss of smell and taste. So this is the time after 3 weeks when we realized that the symptoms were still persistent. We prescribed 1 dose of influenzinum 200 and followed it up with CPR 200, which is her, the deep acting constitutional medicine. And that helped clear the entire situation in couple of 3-4 days. So the cough went away. There was no dyspnea. She maintained SpO2 very well later on also. And all the remaining symptoms which were there went away. So this COVID, did not get settled in a week or a week's time. As you could see the other earlier cases, even though they had pneumonias, they would settle down by 4 to 8 days maximum. This COVID extended to 2 weeks or beyond. And that is the time when we introduced influenzum. So Naxwamika was the acute part of it, followed it up with a nosode of influenzinum because the recovery was slow and delayed, then followed it up with the constitutional medicine. So this is this is her chest CT, and we also did her COVID antibodies, and they turned out to be, she had developed robust antibodies at that point of time. This patient, again, what I'm trying to show here is that COVID positive on 13th, okay, symptomatic since 7th, positive on 13th, so that's 1 week. 26th better, but on 31st again developed symptoms. So you see, there was recurrence of symptoms after almost around 15 days after being better. And at that time, there was dyspnea on climbing stairs or walking even while talking. Okay, patient was home and then developed symptom. The thirst increased for sips of frequency, and RT-PCR was continued to be persistently positive. That is the time when we introduced arsenic album, which settled the dyspnea. But what was important is that the dyspnea still continued for another 2 weeks gradually. And the RT-PCR continued to be positive. That is when we gave tuberculinum 1M as a nosode and followed it up with silica 200, which was the constitutional medicine. Followed it up does not mean giving it on the same day. Give tuberculinum 1M, wait for 48 hours, and then follow it up with the constitutional medicine. So, and that, again, we checked the antibodies, which turned out to be positive, and the RT-PCR turned to be negative. Now, this is very important. So you see, there are cases which showed very prolonged course as well. And those are the cases which required 3 remedies. By 3, I don't mean prescribing 3 at one point of time, prescribing them sequentially. One is the acute, followed by nosode, followed by the deep acting constitutional medicine. This was the pattern that we followed for cases which were taking more than 2 weeks to respond to this entire phenomenon. Now, this gentleman was COVID positive 5 times. He tested 5 times and was COVID positive. His hospital discharged him on a positive status and advised for a 15 days quarantine. And each time he tested, it turned out to be positive. You could see that report number 1 on your left, report number 2 on your left, on your right, report number 3 on your left, and report number 4 on your right. All of them persistently positive in spite of the fact, and the patient remained to be symptomatic. So the hospital had no other this thing but to discharge them, and they were discharged. And he came to us asking for help because he was just not turning, his symptoms were not going away, and everything that was to be done, antibiotics, antivirals were done, and including the steroids, and yet he was positive and persistent with symptoms. So 5 RT-PCRs coming positive, and his IL-6 was 2.3, CRP 4.3, ferritin was LDH, everything was done. And we repeated it on 22nd before starting the treatment. It was positive at that time as well. So, the current symptom is that he was apprehensive for last 1 month. I am positive in spite of doing everything. I still have a headache which is persistent. I have a chest pain which is left-sided and it is of a stitching type. And then, so we looked at both the pictures, we looked at his original unmodified pictures and we looked at what are his residual symptoms. So he got wet in the rain, he had fever, headache and body ache. And now what was remaining is headache on the vertex and stitching pain in the chest. And persistently coming to be COVID-19 positive for last 1 month with 5 tests being done. So on 23rd, we giving influenzum 201 dose and prescribed Bryonia 200 4 times a day. On 26th, he reported no very mild headache, no chest pain at all. And 29th, we advised his RT-PCR when he was completely asymptomatic. And there you see that his RT-PCR on 29th itself turned out to be negative. So only when he came for homeopathic treatment after having done everything in the world, and we could see the original unmodified picture and the residual picture very, very clearly. So we used the remedy that covered both the original unmodified picture and the residual picture. And before that, because it was a long COVID, we introduced an nosode. So you see we have introduced 2 nosodes. One is either tuberculinum and the second is influenzinum, depending on what is the persistent symptom. So now we move into the last phase of COVID-19 with comorbidity. So this is a case of a case of a renal transplant which was done in 2016 with IgA nephropathy, due to IgA nephropathy. And during COVID, the graft got rejected after 4 years, which is such an unusual situation. And the creatinine had stepped up to 9. And so with that, patient complained with low-grade fever, leg pains and cramps. RT-PCR was detected positive on 15th, and there was a huge panic because the creatinine was 9. The graft had got rejected during COVID, and there was a situation. Again, we asked the person, tell us the first 3 or 4 important symptoms that you felt when all these things were happening, and you would be surprised to see there was eructations with cough. There was bloating sensation with abdominal pain. So no renal symptoms. You see, there was eructations with cough, there was bloating sensation with abdominal pain, and there was dyspnea with bloating sensation. Simple. So we prescribed again, and the CT was showing pulmonary edema with left lower zone collapse. So this is not, though she was COVID positive, this CT findings were not due to COVID. The CT findings were due to the cardiorespiratory issues that were going on. So we prescribed Carvoage 200, and the moment she said I was feeling better, we told her that repeat your COVID as early as possible, because she was not going to be taken in a dialysis center if her COVID was going to be positive. And you can imagine somebody's creatinine being 9 and the kidney graft getting rejected and not being allowed for dialysis meant impending, literally meant impending death. So on 15th, she turned out to be positive. On 15th, we prescribed. On 15th evening, she said, I'm already started feeling better. My dyspnea is less. So we insisted that, please go ahead and repeat your test as early as possible. She did a test the very next day with single dose of Carbovage 200. The abdominal distension went away. The dyspnea went away. The cough went away. We repeated 2 or 3 more doses of Carbovage and repeated a test the very next day, which turned out to be negative, and she was allowed in the dialysis center thereafter. So I think to us, these are very, very important cases where, homeopathy can be applied under all situations and all circumstances. I have been showing you pneumonias where we, have used like Naxwamika, Bryonias, and Pulsatillas. Now this is where we are using Carbovage. So nothing new comes up. No such no you know n- uh, nothing unusual or very complex or something. No new theory has to be evolved to treat COVID. This is the point that I'm trying to drive home all the time. Now, here is another peculiar case where the mother was 9 months pregnant and turned out to be COVID positive when she went into her ANC checkup and she had to be delivered. Now, what do we do with such situations? You can't give antivirals here. You can't give, and the patient is febrile and symptomatic. So here again, we prescribed Bryonia. She was afebrile, went to the hospital for investigation Monday for blood test and RT-PCR, developed fever again with loose motion. So Bryonia here did not work, and we had to move to Arsenicalb. So we gave Arsenicalb 204 hourly. She was positive while being 9 months pregnant and was about to be delivered. And you can see that even her chest CT was showing, positive signs. These were CRP levels, and you could see that the CRP level was shooting up. D dimer was, all other things were normal, but the CRP levels had gone up. The patient turned out to be afebrile after Arsenicalb with no cough and breathlessness. Patient was taken up for LSCS, and we restarted on after the once the orals were started. We restarted with Arsenicalb, completely asymptomatic and discharged. So you could see that there are special circumstances where there is no other option left. The mother and the child both are at risk, and we tried very simple things like using Bryonias and Arsenicalbs with no big thought process or rocket science involved into it, and it helped. So as I said in my initial slide, we have now seen that we could use homeopathy in general prophylaxis with Arsenicalb in the general community. Then we used what Dr. Dikshit and we worked upon as Zinkum Met plus China Ars and Calcarea Phos for primary contacts of COVID positive patients. And as you could see that the positive cases were just 1 in 35, or out of 1200 only 79, that's around 0.6% stayed positive. Nobody died and everybody could be managed at home. Then we had this asymptomatic outbreak in an office where we took symptoms of 8 patients who were exactly same symptoms. So based on that, we decided what is going to be the remedy for asymptomatic positive COVID patients when they are not exhibiting symptoms but they have been positive together. So it was almost like an outbreak of an epidemic within an epidemic. So we prescribed Bryonia to all of them, and all 92 turned out to be negative within in first 1 week to 10 days. So this is how you treat. This is how we try to manage a general population, high risk population who are exposed to COVID, asymptomatic COVIDs who are in an outbreak, and then individualized homeopathy for those who are exhibiting individual symptoms. Mild COVID to mild symptomatic COVID to moderate symptomatic COVID with pneumonias, and COVIDs with comorbidities with life-threatening issues like creatinines being 9 and cardiac failure setting in, or women in pregnancy who are about to be delivered and turned out to be positive. So everywhere homeopathy could be applied. That is my first heartening thing. Second thing, nowhere we had to do anything other than just simply applying the basic science of homeopathy. Third, a lot of allopathic drug load could be stressed, because you could see that some of these patients then later on themselves said that we don't want to take antivirals. The women, pregnant women, did refuse to take antivirals. The person who had the creatinine 9 did not take antivirals or antibiotics. So what I'm trying to say here is that if we are able to and then we evolved a pattern, we understood what was actually happening out over there. We were a part of this project where we were collecting data from 13 countries for over 5 months, and uh, Argentina, Austria, Belgium, Brazil, China, France, Germany, India, Iran, Italy, New Zealand, Turkey, and USA. All these countries were collating data, and it will be surprised that you would see that 415 positive patients from all over the other countries, and much more getting added up. This is an analysis that I did when we were 415. Now many more have got added. You can very clearly see that the top remedies that were coming up were all that we were using in our work here: bryonia, arsenic, pulsatilla, nux vomica. All these were remedies that we were using here, and this is precisely, that means what it said is, one second, yes, that 75% of your cases are covered by the top 6 remedies, or rather top 7 remedies, and the rest 3 are only adding to 5%. That means if you are able to, you know, uh, understand one of these 10 totalities that are coming up, you have covered 80% of your homeopathic prescriptions in COVID. Very, very simple. And I think none of these remedies are such difficult to understand, or difficult to follow. Anybody who is even averagely skilled in homeopathy or can prescribe these remedies. You don't need a super prescriber in homeopathy to handle these particular things. This is the analysis that threw open the entire gates for us. And no, so this was the pattern of prescribing. Around 30 to 40% of world prescribing was bryonia. Around 22 to 23% was arsenic. Around 10% was gelsemium. And this data help us understand that your first 10 remedies is what covers 80%. And all these rest of the 20 remedies, if you see on the right side of your screen, Mercor, Senega, Justicia, Chelidonium, Merck, everything was just that 20%, and each of these remedies were just prescribed a very few often. So most important thing was to understand this 80% of the cases on your left of your screen. Now we also realize that no genus epidemicus is going to come. That's very, very simple, because people were exhibiting different expressions, and those expressions were, except for the outbreak where we saw all 108 patients exhibited same symptoms, everywhere else we found that different people exhibited different symptoms. So, and if genus epidemicus was to come, this is an imaginary graph. If genus epidemicus was to come, say R1 was your genus epidemicus, then your prescriptions, all your prescriptions should have been grouped here near the R1. And that could have been one remedy, or maybe just 2 remedies like R1 and R2 would have been the 80 to 90% of your prescription. But here you see, we ourselves saw that though bryonia was prescribed around 35-40% of the times, and arsenic was prescribed around 25 to 20 to 25% of the times. So bryonia did not come up here as R1, neither did arsenic come here as R2, where they were prescribed more than 80% of the time. No, that did not happen. So this entire analysis led to us to understand that no genus epidemicus is likely to emerge in at least this particular epidemic. So what were we doing? I'm now trying to make you kind of retrospectively understand what exactly we were doing there. What is it that those 3 symptoms that we were looking for? We were looking for speed, we were looking for order in which the symptoms evolved, and we were looking at the association of symptoms with each other. That's it. We were looking for speed of the illness, how the symptoms evolved. We were looking for the order in which the symptoms evolved, and we were looking for the pattern in which each symptom was associated with other. Let me explain that to you in a little more detail. What we meant by speed is whether the illness is slow or rapid. Okay, that would tell us what is happening, whether the symptoms, what are the clinical symptoms. I'm not talking about characteristic symptoms, I'm talking about in the order in which simple clinical symptoms evolved, and then what were the association between this that had evolved in the entire acute picture. So first prescribing part was acute or rapid onset or a slow onset. Anybody can discern that. And I actually ran the analysis through the data table. And these are the different patterns that came up. You can see here there are scores here: 4.08, 3.45, 4.57, 0.061. These are weighted averages of symptoms in which the patterns evolved. So you could see no single pattern of symptoms have evolved. You can see here I have done study for many more, but I'm displaying 6. You can see all 6 remedies displayed statistically different patterns. And this is precisely what I'm trying to say, that is the reason I'm saying that no single pattern has come up in this particular epidemic. And that is the reason I'm trying to title this talk as Understanding the Patterns. So the arsenic pattern was different from bryonia pattern, and bryonia pattern was different from pulsatilla pattern. And this could be statistically understood by studying the data, and these patterns have evolved after the statistical analysis. Okay, this is called a spider web diagram, and it is done to show patterns of various types. So what were these patterns when you look at in the clinic? So if the pattern was fatigue, apprehension, cough, and thirst, right? Here you don't see myalgia coming very early in the thing. It is going to be an arsenic pattern. So you see here the arsenic is the fatigue is getting pulled up. It has the highest score of 4.08. Then a very slow onset that is getting pulled up. And then the next third most prominent thing that came up. And these are all symptoms which were exhibited by patients who suffered from COVID. This is not some theoretical analysis. This is the analysis of symptoms of patients who suffered from COVID. Okay. So this is how the patterns of arsenic evolved in arsenic patients. So if I could see the 3 symptoms coming up very quickly: fatigue, a gradual onset, and apprehension, I would be more than happy to prescribe arsenic in that patient. I would not, wait for other symptoms to develop. Now, when I look at the association part, what is the association? If I see an association of fatigue as the main crux with slow onset and a correlation between anxiety and thirst, yes, that's arsenic pattern. Now, this is on your left. You see, this is what our textbooks say: great prostration with anxiety, thirst for sips, cough, breath. So our textbook picture was slightly different from what was actually seen in the clinical scenario. Though the fundamentals remain same, I'm not contradicting the fundamentals of the textbook picture, but the clinical patterns were slightly different. They were not as elaborate as our textbook pictures are, but the clinical patterns were nevertheless very clear that arsenic would get indicated if there was prostration, gradual onset, and apprehension. Now, what was a bryonia pattern for that matter? The bryonia would get indicated in 2 things. There has to be a myalgia, ache. Fatigue had to be there with body ache, and the dryness and the cough. So you see, dryness was exhibited as people saying I'm constipated, dry pain with chest, dry cough, chest pains. Even people, if you remember, I showed a case where there were only 2 symptoms: constipation and dry cough, and that patient actually had a pneumonia, subpleural pneumonia, right? So you could see that, if you could see that there is a gradual onset with dry cough and dryness as a general with myalgia coming up, if you see these 3 symptoms coming up, it is more often bryonia than anything else. And that is why you see all our patients where we were only focusing on, tell us the first original unmodified symptoms of yours, first 4 or 5 original unmodified symptom before you took a paracetamol, before you took an antibiotic, before you took a antiviral or whatever you call it. And that order of symptoms gave us the remedy. Okay, so this is the pattern for bryonia. You see, dry cough, headache, thirst change, and slow onset is bryonia. Now, gelsemium. The pattern for gelsemium is different. You see the pattern for a bryonia, the graph looks different. The pattern for a bryonia and gelsemium is looking very, very different. The fatigue and chilliness is very, very important in gelsemium. The fatigue and the chilliness become extremely important, and drowsiness become important in gelsemium patterns. Very less prescribed. I mean, you could see here, I'll show you the graph once again. Not as frequently prescribed as bryonia and arsenic, but nevertheless an important remedy that was getting prescribed all over the world, mind you. And now this data is not just our clinic, which was around 300 odd patients, but this data is from all over the world. So the data is more than 500 cases that I'm talking about at this point of time. Camphora, again, very important in prescription. Most important thing was the rapidity of onset. This was the remedy which had sudden fatigue and exhaustion. Here, ache was not important. The muscle ache was not important. It was the fatigue that was very, very, very important at that point of time. Whereas in bryonia, the aching was important. Whereas here it is sudden weakness, sudden loss of taste. And they presented with two sets of symptoms, either with complete anesthesia, okay, where they say nothing is happening, or with tremendous anguish and anxiety. So camphora was used in patients who were on ventilated. Suddenly they had happy hypoxia and dropped. We used camphora there, mainly with people who had huge comorbidities, and they were, used camphoras when they had multi-organ failures with, saying nothing is happening, but their creatinines are rising and they have other symptoms, neurological symptoms which you've seen. So you see, camphora pattern is much, much different from a bryonia pattern. So sudden fatigue, dry cough, and camphora would invariably throw a symptom, neurological symptom. Sudden fatigue, breathlessness, and a neurological symptom, either loss of smell, loss of taste, or a profound weakness. So this is what camphora pattern was, and the two extremes: complete anesthesia, where somebody says, "Oh, nothing is happening to me, I'm all fine," when the parameters are going bad, or an complete or an anguish worse than arsenical, an anguish which is worse than arsenical. So that was the camphora picture that we found. And pulsatilla, you see, very slow onset, very low grade symptoms, fever. Even though there is a pneumonia, the fever is like 99, not raising, not getting more than 100, and thirstlessness, again, losing smell. So these are things that, the pulsatilla pattern came up. Mainly, you would see that there were upper GI symptoms associated with pulsatilla, dryness of mouth and all other things. So dry mouth, loss of taste, loss of smell, low grade fever was, more like pulsatilla. So again, this phosphorus pattern is, one of those where you very see a very insidious onset, but a very, very rapid progress. So this is a dual game. The onset is slow, but the progress is very rapid. And you will see that the fevers are high, and the patients would have apprehension. But the most important thing is the cough and the blood and the chest pain that would come up in phosphorus patients, even in COVID-19. So you see, the orders are different. Arsenic order is not deep cough, chest pain, dyspnea. Arsenic order is different. 1, 2, 3 in arsenic is different. 1, 2, 3 in phosphorus is different. So all I'm trying to say is, in individualization can be practiced to the core. You don't have to compromise with basic principles of homeopathy to apply homeopathy even in the most desperate situation. This is the point that I'm trying to drive home. We have individualized the patients whenever the patients have come with individual characteristic symptoms. So how does this way of prescribing help? See, first of all, 75% of your prescriptions are evidence-based. They are coming from cases who have been COVID positive and whose data has been recorded and studied and analyzed. So you are based on your data. Your prescriptions are based on evidences of treated COVID patients. That's first part. So you're not shooting in the dark. You're not theorizing. You're not conceptualizing in the dark. in air, as you say, the time required for case taking becomes drastically less. We are just focusing on give us the original unmodified picture with 3 or 4 first 4 symptoms and the order in which they evolved. That's it. The rest is all clinical case taking, which takes 5 to 7 minutes. And documentation another 5 to 6. So 10 minutes the patient is out. Whether it is pneumonia or whether it is a pediatric child or whether it is a pregnant woman, whatever it is, in 10 minutes your patient is done. So you are treating almost you have become a general practitioner. Okay, and which is very relevant now because you're treating high number of patients. You don't want to get exposed sitting there for 1 hour in a front of a COVID positive patient. Whatever be your protective gear that you are using, more the exposure, more the chance of you getting infected with COVID. Second, what we realized, so cutting down the time was very relevant and it was very practical and we could do that. Second thing was, prescriber can be trained to observe these patterns. It is not something that you cannot train. No need for any highly skilled prescriber. So this can be replicated in many, hospitals or many clinics at any given point of time. The method can be replicated easily. You don't need a very high skilled prescriber to sit there and think about what is that complex symptoms of this mind and any other thing. No great interpretations required over here. It is a scalable method. That means if I can do it, I can teach it to 3 other people and they can teach it to 4 other people, and it can be scaled up. So it can be used on a mass scale, and it has a large scale application. So essentially what we are trying to see is, now what I'm going to show you is just how we classified the remedies. So we prepared a grid of how to identify the remedies and by clinical stage how to see them. That's it. So this is for prodromal. These were the group of remedies that we were looking for, and only these symptomatologies were coming up in COVID. So we were not even looking for anything beyond this. This is coming from our original reference textbooks. You can see these symptoms anywhere. There were prodromal, people were coming with prodromal symptoms. This is what was, these are the group of remedies we were looking at. If patients were coming with initial flu-like symptoms, Bryonia, Merxol, Eupatorium, Gelsemium, Rustox is all that we were looking for. These were the prominent symptoms that were there on our screen when we were looking into them. If people were coming with mild symptoms with pharyngitis, Belladonna, Merxol, Hiparsulf, Arsiode, Calimure, most of them would fall into these categories. This is the next part of it. If there was early lower respiratory infection, that means the pneumonia is setting up. Bryonia, phosphorus, arsenical, ipecac and antimony tart, of which we did not see ipecac coming up very much. Antim tart, yes, we did see antimony tart coming up. Lower respiratory infections which were properly set in with breathlessness, antimony, ars, phosphorus, kalicap came up more often. Lycopodium came up. Chelidonium was hardly seen, but I am sure there are a lot of people who have prescribed Chelidonium with good results as well. I know about it. I did not do it, but I can say that it was seen. Lower respiratory symptoms with secondary infections. That means when there was a bacterial infection coming up, Stannum met, Merxol, Hiparsulf, Calibicromicum and Natrum sulf. These were the remedies that came up during that time. With cardiac comorbidities, Arsiode, I have seen Arsiode and Viratrum viridi coming up more often. Ammonium carb was prescribed. I have seen that. Kalicarb has been used by a lot of physicians who have treated cardiac comorbidities with lower respiratory infections. So yes, these were the remedies that stood up very prominently. And people who were in ICUs and septicemias, I have seen Hiparsul being used, Crotalus being used personally, and not much of muriatic acid. Let's be very, very frank. Lecasis in very final and terminal stages, yes. You saw a case of carbovage. I would narrate a case of aspidosperma right now if you can, if there is time. But aspidosperma has come up as one of the remedies where patients have presented with lung fibrosis with cardiac comorbidities, especially developing cardiopulmonary circulation compromise and hypoxia coming up as a prominent symptom. Especially in post-COVID, aspidosperma is coming up very, very strongly, and there are cases where we have prescribed aspidosperma as well. You saw carbovage. I showed you a carbovage case, aspidosperma. This is the second slide for that. And the cytokine storm, Cuprimet, the sudden onset and collapse and spasms. Camphora, again, sudden rapid inflammatory fevers with asphyxia and laryngeal edemas. Belladonna has come up with sudden onset. Yes, belladonna and arnica. There are research papers on belladonna and arnica on cytokine storm. Prescribing. So please have a look at them as well. And you saw slow and delayed recovery cases that we showed you. We have used Carbovage here to improve the recovery if case comes to a standstill. You saw us using tuberculinum and influenzinum. We did not get a chance to use Thuja as such, nor did we get a chance to use Sorinum. But 2 out of these 4 definitely we have used, and I have shown you the cases that were there in the prescribing. And yes, ferrum phos has been used by us in 6x potency in many cases where, not in the cases that you saw, but in many cases where there was only fever for a day or two. Ferrum phos 6x was used, not 30. We used ferrum phos 6x for in the first day or first hour of fever, we have used ferrum phos 6x. Thereafter, people did not have fever, so they did not report. So as you can see, it is all about understanding the pattern. The dosages for homeopathic remedies should be repeated on clinical severity of illness with close monitoring and clinical progress. We have repeated the dosages. Very few cases have improved with single doses, but most of the time it has been 3 or 4 doses that have been repeated, and it has been tapered off as the clinical progress has happened, as the patients have improved clinically. Remedies can also be prescribed on sequential and complementary relationship, as you have seen in the earlier cases as well. Biochemic we have used in 6x potency, and most of the time the dosages has been 4 times a day. So this probably answers the question on biochemic as well. So the conclusion is that homeopathic treatment for all stages of COVID-19 should be based on peculiar symptoms exhibited by individuals suffering from illness. Typical diagnostic symptoms of COVID-19 are important to identify the stage of illness, the typical diagnostic symptoms. But individuals suffering from COVID-19 illness exhibits definite clinical pattern based in each stage of disease, which are very peculiar. This is something that one needs to identify. You have common symptoms, but those common symptoms get evolved in such a way that you are able to see the peculiar pattern that is getting unfolded in front of you. And these patterns, when observed, should help select the indicated remedies. This is what I was trying to show you through those statistical analysis and the graphs that were there. All treatment guidelines mentioned are suggestive and should be adopted, by only a qualified homeopathic doctor. I urge, COVID-19 should be treated by only qualified homeopathic doctors, because there are complexities involved, which we need to observe. Though I'm not trying to say it is rocket science, but on the other hand, I'm also cautioning that it should not be treated by by being not trained into clinical medicine and not trained into anatomy, physiology, and pathology of the illness. So we always had this thing, the first line of action and the second line of action for all the phases of COVID. So in pattern 1, where there are no symptoms, that is what we are saying, prescribe on the premorbid symptoms. First line of action is to select a remedy on premorbid symptoms. That is where the symptoms that were there before COVID. The second line of action is what we saw most of the time, treat the acute symptoms with the original unmodified picture of the acute totality that comes up. That was the pattern 2, which was seen in many patients, and that's where you saw most of the times in our presentations. As these indications are based on the peculiar modifying sensations and factors, we saw all the sensations coming up. The second line of action is, if these acute remedies don't complete the response, then you saw some of the cases where we have used a constitutional remedy to complete the action of the acute remedy. So that is the second line of action that was there. And the third pattern that we saw is prolonged convalescence in COVID patients with protracted symptoms. Ideally, use a indicated remedy mentioned in the convalescence section. That's where I showed you tuberculinum, influenzinum, carbovage, zinc-met, and even sulfur. But most often we use the nosode to be repeated very infrequently. And the second line of action after the nosode is to prescribe the constitutional medicine. So this is how we have clearly demarcated on the first line of action and the second line of action in each stages of COVID-19. So my deep acknowledgements to my colleagues and our team at COVID Task Force in Maharashtra, which where I am one of the members, and we are deeply involved in spreading Ayush systems of medicine in COVID-19 situation in Maharashtra. It has been led by Padma Shri Dr. Tatyarao Lahane, who is an ophthalmologist and he's the directorate of education and medical research in state of Maharashtra. It is ably supported by Dr. K.R. Kohli, who is the co-chairman and Ayush director for Maharashtra. And we have experts from all the systems of medicine whose primary job is to generate intellectual knowledge based on data and research, as well as in patient management, taking direct interest in patient management, and to generate strategies and protocols and advisories. We have released two advisories for doctors in Maharashtra for using Ayush systems of medicine. Many of what you have seen in this particular presentation as well. I'm also thankful to my team, my entire Ayush COVID Task Force team, because they've been highly supportive. And I'm very glad to see that all systems of medicines have contributed significantly, and we have now started Ayush immunity clinics, which will be the first of that sort for post-COVID. For pre-COVID, and we will also be including the post-COVID complications and sequelae in that shortly. So we come up with two advisories, immunity clinic, and now we will be coming up with the post-COVID, advisory as well. So this is from my team in Maharashtra. I'm in great thankful. I'm absolutely, thank you to American Institute of Homoeopathy, because we've been a part of the data collection project since March, and we've been part of this, and we've been contributing and reviewing and analyzing the data all through coming over from all over the globe. So thank AIH for doing this. And the last slide. There we go. Yes, and this is where Ariv Integrative Healthcare is situated. It is, and you can see these two great gentlemen in the center of the slide, Dr. J. Rameshwar Rao and Dr. Pauluri Krishna Chaudhary. They are truly inspiring to the entire team of Ariv Integrative Healthcare Private Limited, which functions from Yashoda Hospital premises. We are a part of the Yashoda Hospital, and we function from there. And you can see these were two gentlemen who kept us going through the tough times during COVID-19. So thanks to the entire Ariv team. It's a very dedicated and small but a very comprehensive team. And so I'm very happy to be a part of that particular team. And thank you for your patient hearing. And I end my speech here. I'm open to any questions or queries that are there. I hope we still have probably 15 minutes to go. So thank you very much. And I look forward to the questions.
Thank you very much, Dr. Naveen Pavaskar sir, for your wonderful presentation. It was highly educative, well documented, systematic, and highly organized research work, which was highly informative for all the homeopathic. So now I request our today's chairman of this webinar session, Dr. Mahesh Kumar Gupta sir from Gwalior. He is a former principal and professor of organ of medicine and homeopathic philosophy in VRH Medical College, Gwalior. He has been former president, Central Homeopathic and Biochemic Association Foundation Society, VRH Medical College and Hospital, Gwalior. He is former subject expert Public Service Commission PSC Madhya Pradesh, and he has a large experience, clinical experience of more than 45 years in chronic and complicated cases, and he is our chief coordinator, Indian Institute of Homeopathic Physicians, Madhya Pradesh. Now I request Dr. M.K. Gupta sir for his valuable suggestions, and he can also take up the questions from the chat box to ask to Dr. Naveen Pavaskar sir. Over to you, Dr. M.K. Gupta sir. Thank you very much.
Thank you.
Sir, your voice is not audible. Please, can you come closer to your mic?
Hello. Yes. Am I audible?
Yes, you are. You are better than, yeah. You can even come more closer to the mic. Yes, sir. Yes, sir. Yes, sir. Please, please go ahead.
Am I audible? So, thanks, Dr. Tanvir.
Yes, sir. Yes. Start talking, sir.
First of all, I would like to congratulate a learned speaker, Dr. Naveen Pavaskar, for his nice presentation on homeopathy in COVID-19 infection. No doubt, Dr. Pavaskar has covered all the important aspects on a practical basis, step by step, in a systematic way. He has addressed all the issues precisely in a very and a successful potential role of homeopathic system of medicine in infection like COVID-19. Let me say a few words. I have nothing to say much more about the presentation. It is very inspiring, and it is the practical application of the fundamentals of medicine. For the last 7-8 months, waking, eating, drinking, watching, we are advantage not only in the body but advantage in our mind, and since the very inception of COVID-19, there has been of confusion and uncertainties regarding the nature and the treatment of the new virus. Constantly changing tools and the contradictory statements of the scientists all over the world have been noticed. Apex body of the medical world, WHO, took the number of U-turns. During this 7-8 month period, number of drugs have prescribed, sometimes antibacterial, sometimes antiviral, anticoagulants, antimalarial, which is short, plasma therapy, and at last, mixture of all. Now everyone is getting and ready for making for new arrival of coronavirus, which is also highly disputed, should be effective or not, only God knows. Friends, if we look back into the history of the medical world, this situation is reminding us the state of medicine of the 18th century. The medical world, the total darkness, as regards the nature of the disease and the treatment. There were advices, ideas which now seem absurd, were then matters of the most important example. During the statement, extremes, the so-physiological medicine was carried. More than 6 million leeches were used.
Dr. Yashpal Sood, kindly mute yourself, please.
Yes. Hello. Am I not?
Dr. Yashpal Sood, please mute yourself. Dr. Yashpal Sood, please mute yourself. Carry on, sir.
100,000 pound blood was spilled in the hospitals of Paris. In 1 year, the mortality was appalling. In Harriman's time, the death of George Washington was undoubtedly caused by the repeated handwriting to which he was subjected. Even though these quite unscientific approaches were considered highly useful and logical, and in those days, no one, any sensible person could oppose this humanly method of the treatment. No doubt, everyone knows lots of changes have been taken place in the medical science. Then all these crude methods of the treatment has been stopped. Number of new scientific and technological advancements in the emergency and the surgical field have saved the life of millions. But unfortunately, still, the therapeutic part of the dominant medical system more or less remain in the same level. With the result, modern medical prescriptions and medications have become the third leading cause in Europe and America. Even then, our medical colleagues are not ready to learn the lesson from the past. Dr. Samuel Hahnemann, a great genius revolutionary scientist, medical reformer of his time, appeared on the scene in the 18th century, who guided the misguided and confused medical world. Today, his teachings are still equally relevant and need to be followed for the betterment of the suffering humanity. Today, the chaotic world needs to understand and realize what the founder of homeopathy says in his important work, Organon of Medicine, in order to remove the great confusion and uncertainties of the medical world. What should be the proper remedy for COVID-19? What Dr. Pavaskar has explained. In the physician, if the physician clearly perceives what is to be cured in disease, that is to say, in every individual case of disease. If he clearly perceives what is suited in medicine, that is to say, in each individual medicine. And if he knows how to adopt accordingly clearly defined principle, what is curative in medicine to what he had discovered the undoubtedly morbid in the patient, so that the recovery must ensue. Diseases are cured by administration of drugs. Unless law of cure is discovered, that is the general law of interpretation, interrelation between diseases and drugs is discovered, established scientifically through observation, generalization, induction, and experimental verification. The art of cure cannot be practiced with certainty and uniformity. It is just failure to discover such a law of therapeutics that handicap the art of healing and made it so absurd and fanciful in 1,001 ways. A so-called modern scientific system still refuses to recognize this law. And that is why the therapeutic branch of the system is in such a weak point. Hahnemann had discovered such a law for once, let likes be treated by like. After going through all the necessary steps used for a scientific investigation like observation of facts and repeated experimental verification, first time in the history of medicine, Dr. Hahnemann, our master Dr. Hahnemann, established the therapeutics on the scientific ground. Homeopathy rests upon certain fundamental principles and laws, as all of you are well aware, like similar principle, drug proving, drug dynamization, and the vital force. Each and every one is based on the pure observation and facts and confirmed by myriads of subsequent experimentation, and have also been verified clinically for about more than 200 years throughout the world. And today's presentation of Dr. Havas is the best example of that. What a ridiculous situation is homeopathy and homeopaths have not been allowed to treat this coronavirus on the ground that homeopaths have no scientific evidence. Despite of the fact that thousands of evidences are available which prove and showing the efficacy of homeopathy to deal very successfully with any kind of epidemic, endemic disaster. Central Council for Research in Homeopathy has also produced a fact sheet. Hello? Hello?
Dr. Yashpal Sood, please mute yourself. I am requesting you repeatedly, please. Please.
Central Council for Research has also produced a fact sheet containing number of references showing the successful utilization of homeopathic medicine in different epidemics. Dear colleagues, homeopaths are not hunting or running behind the microphone. We have seen in the cases of the Pavaskar and so many cases have been dealt without giving the antibiotics and antiviral medicines and successfully cured. They have been cured. Homeopathic medicine is based upon sound principles and the law of nature. Unlike so-called scientific medical theories, which are constantly changing, law of similia is eternal. It is applicable to all forever, whether it is SARS, Ebola, swine flu, or COVID-19, 20 or 21, and so on. Homeopaths world over have been treating highly infectious diseases without using any antibacterial or antiviral medicines. Millions and millions evidences are there. I myself have treated very successfully number of multi-antibiotic drug-assisted cases very successfully. All these evidences are deliberately denied or ignored by the so-called modern scientific system of medicine. At the end of my speech, again I would like to congratulate Dr. Pavaskar for a very nice presentation and for the practical application of the fundamentals of system of medicine. I wish to appeal to all our scientific, sensible colleagues of the different medical branches. Every system of medicine is having its own limitation of its own. Let us be broad-minded, open-hearted, come together and join our hand to fight with the evil disease forces for the betterment of the suffering. Thanks to all for hearing me patiently. Wish you all a very, very happy Deepavali and New Year advance. Thanks, Doctor.
Thank you very much, Dr. M.K. Gupta, sir. Before offering my vote of thanks to the profession, Dr. Naveen Pavaskar, sir, is it possible to take one or two, three questions from the chat box?
Sir,
If you have already been through this chat box, then we can have one or two questions, important questions you want to answer from this chat box. There is one question that after giving any nosol like tuberculinum, how many hours we should lapse before giving the second medicine? 48 hours or 24 hours, or how much time we should give, sir?
sir, a minimum of 48 hours. Am I audible?
Yes, sir, very much audible.
A minimum of 48 hours.
Right. Sir, there is now. Yes, you are audible, sir.
तनवीर सर, हाँ, आप सवाल पूछ लीजिए ना सर, आपको दिख रही है.
मैं पूछता हूँ सर. Sir, there was one video viral on our WhatsApp groups that WHO has taken U-turn, that it says that those who are asymptomatic COVID patients, they need not to take any quarantine. They need not to, because they cannot transmit the infection to the other person. What are your comments over it?
Sir, I have been studying this epidemic now for a long time, and I feel that statements should be substantiated with evidences for before it can be used as public health intervention. So I would still go by the old convention of following the social isolation and other hygiene measures, and not go with the new thing as of now, because the final word in COVID is not yet out. So I would stay with the old research papers that very clearly say that it is transmissible. It is a droplet infection and it is transmissible. So it is safe to stay with the old thing till the new, the new findings are pragmatically proven. What I mean by pragmatic proving is not proven in the labs, but proven in the practical community scenarios. Right now, the community scenario very clearly states that it is a droplet infection and that it spreads through the droplet thing. So it is better to wear the mask, stay hygienic, do the hand wash, and follow social isolation norms. So that is a better thing to do as of now.
Right, sir. Thank you very much, Dr. Naveen Pavaskar, for your wonderful presentation. And friends, today was really a great day today, because he has so nicely, so systematically, he has given everything. I mean, we can even everybody, I mean, that he can approach these COVID patients successfully if we have this type of understanding regarding the symptomatology. Because the basic problem which we are facing in our clinical practice is the selection of the right symptoms. As Dr. Naveen Pavaskar has told in the very beginning only, that the three original symptoms which he is taking from the patients before taking any allopathic or any other kind of treatment, it is very much from the Dr. Hahnemann's guidelines from 6th edition of Organ. And if I read it, Dr. Hahnemann says the symptoms and feelings of the patient during a previous course of medicine do not furnish the pure picture of the disease. But on the other hand, those symptoms and ailments which he suffered from before the use of medicines or after they had been discontinued for several days give the true fundamental idea of the original form of the disease. And these, especially the physician, must take note of. So thank you very much, Dr. Naveen Pavaskar. We have gone according to the Dr. Hahnemann's guidelines given in 6th edition of Organon. Also, this is the beauty of Organon, that it guides us what are the important symptoms. Otherwise, patient when comes to us, we have lot many symptoms which are totally mutilated, totally mixed up with the effects of the medicines, drugging and all those things. So not easy to take up the virgin symptoms of the patient, which patient had experienced in the beginning before taking any other symptom, treatment. So it was very nice evening, sir. I have learned a lot today from your wonderful,
Thank you, sir.
research work. Yes, of course, it was highly educative. So though the time was very short for you, because we wanted to know the differentiating features of all the material medical you have shown in the last, the pattern of the different medicines, the evolution of all the medicines, though you have given very nicely, but it needs a lot of more time to digest everything slowly to learn all that you have learned from your long study and long research work. So at the end of this webinar, I thank our respected President Dr. M.A. Rao sir, who is the National President of IIHP, for motivating all of us for all these webinars, all these educative platforms. Dr. V.K. Gupta sir, Padam Shri respected Dr. V.K. Gupta sir, who is always a strong support, the spinal cord of our webinars, all CC members of IIHP, all the whole profession which is there, who is attending our program now. And especially I thank Dr. Muktinder Singh, who has taken pains to arrange all these sessions today. He is not feeling well, so he has given this duty to me to host, to take his place today. Inshallah, I hope that he will be there in our next program to perform his duty. Dr. Muktinder Singh, I wish all the best to you get well soon. So at the end of this talk, I request one and all for giving us patiently this qualitative and quantitative time to attend this highly educative program. Dr. Naveen, we would like to have in the future also for valuable information regarding today's webinar. It was highly informative for all of us. So regarding the things which I am looking from the chat box regarding this YouTube channel and all, you can, friends, see all our previous webinars also from our IIHP YouTube channel, and this program of today. This webinar will also be uploaded by our webmaster, Dr. Sudhanshu Aryaji, in a day or two. So thank you very much, Dr. M.K. Gupta, sir, for your valuable comments as a chairman of this webinar session, for your valuable comments we have given regarding this presentation. Thank you one and all. Thank you very much, Dr. Naveen, and everybody. Thank you very much.
Thank you very much. Thank you, IIHP. Thank you very much.
Thank you very much. Thank you, sir. Thank you very much. Thank you. Thank you, sir.